Hello, everybody. Thank you for joining us. My name is Estela Citrin. I am delighted to be part of this webinar. I am a member of the ISSM Education Committee. Next slide, please. I would like to let you know that we are now having the possibility to have subtitles and translation in our webinar. It is managed by your own computer, so you have to change the subtitles in the button that says show caption, and it will have the possibility to have the titles translated into your own language. I would like to remind our friends and colleagues that our vision is that every human being has the right of a healthy and satisfying sexual life. And in order to do so, ISSM has its mission, that is to become the most respected and trusted source of information, education, and professional development in the field of human sexual health. And we achieve this through the delivery of world-class publications, research findings, and both online and in-person opportunities for knowledge exchange worldwide, and this webinar as well. We also would like to thank and acknowledge the affiliated societies that I am sure that we all are part of. And the last slide, please. Just to remind you the possibility that we have to go through the Journal of Sexual Medicine and the Sexual Medicine journals to keep up with the latest research and information in this this topic, in this science. So to begin this webinar about psychology, sexual medicine, culture, sensitivity in diverse communities, we have the moderator of this webinar, Angelica Kolomonska, that she is an experienced and certified psychologist, psychotherapist, scientist, and sex therapist. She helps people establish healthy, loving relationships, and her area of expertise is working with patients in a wide range of sexual and relationship issues as a cognitive behavior therapist and sexologist. She believes that sexuality and self-esteem is an integral part of life that everyone is entitled to have, and I think we all agree with her in that. So, Angelica, it's up to you.
Pleasure is all mine. Thank you, everyone, for being here. Thank you for a kind introduction, and welcome everybody to this webinar on psychology, sexual medicine, and cultural sensitivity in the diverse communities. We'll have a wonderful program, and we'll discuss a very important issue: how cultural, social, and religious backgrounding impacts sexuality, and what healthcare providers need to know to understand sexuality among different cultures. So, those are our presenters for today. And so in a moment, I will discuss the Q&A and how that's going to work. And then I will introduce our first presenter. So Q&A after the presentation, which will be about a half an hour, we'll start to just notice that questions aren't going to happen. We're not going to address questions until after all the presentation have completed. And during the presentations, you can absolutely submit your questions. Please submit them in a Q&A section. And we're going to try answer as many questions as possible once the presentation are finished. And then general comments. If you have general comments, of course, please be sure to make those in the chat. If you do put questions in the chat, well, try to go to do them. But if you want to make sure your questions are answered, definitely put them in a Q&A section. So I would now like to introduce our first presenter. So first presenter is Dr. Veronica Basso. Dr. Veronica is EMDR psychotherapist with international certification, postgraduate in clinical psychology, cognitive therapy specialization, a diploma in generation and gender-based violence, a diploma in systemic therapies, and a title of specific in psychology in health services due to notable competence. Thank you again for being here, Veronica. So take it away, Dr. Veronica Basso.
Well, thank you, Angelica. And hello to everyone around the world. Thank you so much for joining us today. I would like to give my special thanks to the ISSM for the opportunity to be here sharing with you today. So could I have the first slide, please? I have non-disclosures to make. Next one, please. So considering the World Health Organization definition of sexuality, we can fairly say that the way that sexuality is perceived, experienced, and practiced has much to do with social and cultural factors. And what is culture? Here is a definition that I loved from Dinesh Bugra and Conrad Ahmed. They state that culture can be defined as unique behavior, lifestyles, and attitudes which are formed as a result of customs, habits, beliefs, and values that are common to a group and shape their emotions, behaviors, and life patterns. It serves as a core behavior that regulates life. So culture seems to be the way that members of any society use to cope with their world and with one another, and is transmitted from generation to generation through learning. Culture shapes perceptions and life patterns, and of course, that may lead to the adoption of different beliefs regarding sexual activity. Next one, please. The human being acquires the capacity to symbolize, that is, to give meaning to the things that happen. It transcends, therefore, biological determinism of sexuation and overcomes it. Sexual relations between human beings have had to be regulated from clans to the complex interpersonal relationships of modern society. The social fact has influenced sexuation in a decisive way in the development of sexual identities. The sexual body corresponds to a psychological experience that develops in a sociocultural context. Gender roles shape not only the way that individuals receive information and feedback about their sexual conduct, but also the way that men and women give their own sexuality meaning. Next one, please. The International Consultation on Sexual Medicine, the ICSM, states that since sexual difficulties involve a complex interplay of biological, psychological, interpersonal, and sociocultural factors, the biopsychosocial model is a key element in the process of care standards for evidence-based sexual medicine. The biopsychosocial model implies that a functional harmony of these factors is a requirement for sexual functioning, since it can be affected by problems originating from any combination of these factors. Next one, please. Several authors have declared that the dimensions of spirituality in health is so important that we should be talking about a biopsychosocial spiritual model. Spirituality and religious belief give meaning to people's life and therefore can shape patients' opinion about sexual behavior and what is considered acceptable and appropriate. Sexuality is discussed in religious texts and holy books and can be associated with a variety of meanings, including a temptation, a gift, or a spiritual union between married people. Values and traditions regarding sexual meaning, rituals, and practice vary between religions. It is important to take a careful look at how the religious and spiritual factors of the person who consults us may be relevant to the origin or maintenance of the dysfunction. It is also vital to take these factors in consideration when discussing treatment. Next. Following the ICSM guidelines and through the review carried out for this presentation, I would like to highlight the following points. It is important to be aware of the existence of differences in sexual practices, but more important, to explore the difference in meaning of those practices. As we are seeing, the expression of sexuality is not universal. Society continue becoming more diverse, and we are increasingly likely to treat patients with various cultural identities from a wide range of backgrounds. The impact of sociocultural factors on sexual dysfunction is not the exclusive domain of non-Western populations, so consider that meanings should be explored with everyone. It is crucial for the therapy outcome to not assume shared sexual health attitudes. As an example of this, you can ask, what is most concerning for you when you think about your sexual functioning? Or is experiencing pleasure during sexual activity important to you? The influence of cultural aspects is extensive and often invisible because we are all born and raised in cultural context, being influenced by our own spiritual values, internal messages, and scripts on gender and sexuality. In order to be open to the identities of others, we need to be aware of the perspective that we are applying from our own histories. Reviewing the literature for this presentation, I found the debate between cultural competence and cultural sensitivity to be very interesting. Many variations exist in defining cultural competence, but the main concepts revolve around knowledge, skills, and self-efficacy. So being competent could imply that one knows or has mastered another's culture, and this knowing can lead to decreased efforts to learn. Next one, please. Cultural sensitivity approach is a reminder that our understanding of the way that culture impacts each individual patient is always incomplete. Helps having a flexible attitude and asking non-judging, open-ended questions, always from a place of respect and curiosity. Clients do not expect all professionals to be experts in the values, rituals, and practice of all cultures and religions, and are generally willing to provide information. Cultural sensitivity also does not imply agreeing with the client's values, but respecting them without making value judgments. Acknowledge that power, privilege, racism, and sexual prejudice might affect interaction with clients, and that some settings can either support or obstruct the experience of personal volition. It can be challenging when clinicians hold strong beliefs that contradict specific cultural norms of their patients. In some cases, supervision might be needed to be aware of personal feelings and reactions that arise during patient treatment. As sexual health is a basic human right, the principles of biomedical ethics permeates all aspects of sexual medicine. Support the patient experience of autonomy. That is the feeling of being able to make personal, meaningful choices and to pursue health goals that are consistent with one's values and beliefs. An important issue to consider is acculturation. People who migrate to another country would often retain their values and traditions, but would also adopt the values and traditions of the host country. Clinicians should be sensitive to the dual allegiance to heritage and mainstream culture of their patients, and that sometimes they blend together and become a third entity. We should be sensitive to the person's attachment to the religion and potential community need for social support and spiritual guidance. It is important to recognize and explore patients' expectations to avoid misinterpretations and offer culturally unacceptable care. The extent to which religious belief and practice directly affect sexual functioning is generally unknown. Traditional values and rituals that may restrict access to knowledge about sex emphasize restricted and limited sexual behaviors. This could also influence psychological presentations by translating into feelings of anxiety, guilt, responsibility for lack of intimacy, lack of autonomy, and control in intimate relationships. Next one, please. So culture can be pathogenic, pathoplastic, or pathoprotective in mental disorders. There is no doubt that culture will determine how distress is identified and pathologized and how pathways into folk, social, or professional care are identified. So culture, religion included, will determine how discomfort is identified, which problems am I going to be able to realize that I am experiencing so I can communicate them, and also how and to whom am I going to complain about these problems, if I will be able to seek treatment and where is it going to be available. The personal concepts of why an illness has occurred is often strongly influenced by culture or religion. Some symptoms and concerns are not even considered as sexual problems by Western standards. Cultural influence on sexual concepts can cause pathology by creating beliefs that interfere with normal sexual function. There are a number of practical culture-specific factors that are significant in contributing to or perpetuating sexual dysfunction. This can occur through a number of mechanisms such as affecting motivation, creating pressure, intense feelings of guilt, shame, and inadequacy for having certain desires, and of course, anxiety for performance. Next one, please. Pedro Nobre developed a cognitive emotional model of sexual dysfunction in men and women that emphasized the role of sexual belief as vulnerability factors for the development of sexual difficulties. According to this model, demanding and unrealistic beliefs about sexual performance in men, also addresses as macho beliefs, would set a highly demanding standard that makes men more vulnerable to develop catastrophizing interpretation of a sexual event whenever these standards are not met. Some examples of beliefs of men regarding sexual scripts could be all touching is sexual or should lead to sex, men should not express their feelings, and to highly demanding standards related to sexual performance, for example, a real man always have a good erection. In women, sexually conservative beliefs are associated with increased vulnerability to experience sexual dysfunction and hence sexual dissatisfaction. Cognitions of vaginal penetration are one of the possible reasons why women with vaginism avoid penetration. In several studies, religious and cultural concepts accompanied by negative attitudes towards sexuality and a lack of sufficient knowledge were evident among patients with vaginism. Ideas and attitudes can significantly alter the way information is interpreted in sexual circumstances. In this sense, cultural and religious ideas about the importance of fertility, pain, and bleeding during hymen rupture, as well as anxiety and anticipation about the first intercourse, can have a high impact. In patients with vaginism, cognition and perception of their physical appearance at vaginal capacity are often distorted. Some examples of beliefs regarding sexual scripts for women: sex is pleasure only for men, and sex is all men think of. Masturbation is not a proper activity for a respectable woman. Female sex life ends with menopause. Next one, please. So to conclude, I would like to address some aspects of today's culture. In recent years, social media has become an integral part of individuals' daily lives. Different studies have shown that sexual health may be influenced by internet-related activities, but research on the association between sexual function and problematic use of social media remains surprisingly scarce. Unrealistic standards of beauty have been created because of the popularity of highly altered and filtered photos, body ideals, and lifestyles on social media, generating social comparison. Given that individuals have the drive and tendency to evaluate their own social and personal worth based on how they compare themselves, it is clear that social media provides a highly visual, readily available platform in which this type of social comparison can occur. When these expectations cannot be met, people may experience stress, dissatisfaction with appearance, negative self-esteem, and low mood. The interactive nature of social media enables users to publicly comment on each other's appearances as well as their own, creating a complex system of body image and appearance socialization. All of these repeated interactions and triggered beliefs and concerns could elevate the risk of general mental health, problems such as depression, social anxiety, or appearance-related problems, all of which can be related to sexual dysfunction. Next one, please. So for take-home messages, I would like to say, having a culturally and religiously sensitive approach with all our patients allows us to explore all possible factors interfering with sexual function. We should ask all clients about their cultural and spiritual values, and not assume shared sexual health attitudes or meanings. Being aware of our own beliefs and bias is an ongoing process, and more research is needed on how social media is impacting sexual function. Last one, please. So thank you for listening.
Thank you again. It was a great presentation.
Thank
So
you.
our next presenter is Dr. Francesca Tripodi. So Dr. Francesca is a psychotherapist, sexologist, lecturer, and clinical supervisor, president of the Institute of Clinical Sexology in Rome, co-director at the ESSM School of Sexual Medicine, co-founder of International Online Sexology Supervisors, IOSS, an educational platform for lifelong learning in clinical sexology for professionals worldwide, member of the ESSM Scientific Committee and the European Accreditation of Psychosexology, EPSA. So, Francesca, the floor is yours.
Thank you very much, Angelica, and thanks everyone for being here and ISSM for this invitation. Next slide, please. I have nothing to declare. Next, please. So, we need to be aware that cultural diversity is increasing. For example, in the US, Hispanic and Latino ethnicities, African Americans, and other non-white race make up 42% of the population, with such group growing over the past 3 decades. In Europe, with the recent influx of migrants and refugees, cultural diversity has taken on new dimension and impact. In non-Western countries like Africa, Asia, cultural differences are the product of colonial histories combined with the formation of nations based on geographic landmarks rather than homogeneous people. So the result is often a patchwork of regional and ethnic variation. Of course, diversity is also defined by religion, tradition, and subculture values, often assuming a stronger role in contributing to the diversity of thought, feelings, and attitude towards sexuality. Next, please. We have also subcultures within dominant cultures. So populations with special characteristics sometimes establish their own cultural identity and views, values, and attitudes regarding sexuality and gender. For example, we have regional and political culture, body and aging culture, disabled culture, and so on. And coming to sexuality, we may think about lesbian, gay, bisexual, asexual, transgender, non-binary, two-spirits, queer, intersex culture, fetish culture, polyamory, or consensual non-monogamy, the chemsex and the party and play culture, just to mention some of them. Although practitioner will never be able to understand people of every subculture, being aware of such diversity within the population enables healthcare providers to be more intentional in their effort to be inclusive in their verbal and nonverbal communication. Next, please. Diversity and healthcare. So the suggestion dates back to the 70s when the psychiatrist and medical anthropologist Arthur Kleiman described the phenomenon of illness without disease. So the idea that negative emotional states such as anxiety and depression may be somatized in many cultures. Kleiman further notes that people in different parts of the world often have their own conceptual model of disease and how disease should be treated. So understanding diversity and cultural differences has become paramount for the average clinician only in the last 30 years, and a topic of concern that need to be addressed in healthcare. Next, please. So, anticipating such a forthcoming need, in 1978, Kleiman suggested 8 standard questions that you can see here that every physician should ask the patient. If you have a look at those, these questions are meant to explore the patient perspective on their problems without assuming a position of superiority towards them. You can revise this question carefully by watching the recordings of this webinar again. Next, please. I want to spend a little bit of time on this slide because we know that sexual issues represent highly sensitive topics, not just to patients, but also to clinicians. Most of us are not prepared to talk with patients about sexual issues and are not aware of how our ideas about normality in sex are influenced by our cultural context and the culture of medicine and psychology itself. So let's share some snippets on significant and well-documented cultural differences in sexuality. For example, if you think about the social construction of what it means to be a couple and to marry someone is deeply embedded in culture. So the sexes and numbers of people involved in marriage and the expectations of it, from a reproductive partnership to the economic relationship to love and intimacy, reflect context-specific and economical, political, and religious concern. Similarly, some cultures view participation in sex as required or normative for adults, while others value celibacy for those of certain age or social roles. For children born in one country whose parents have migrated to another, messages about sexuality at home may be radically different from those at school, from peers, or in the media, and therefore might be conflicting. So assessing the acculturation degree and the intersectionality of different identities become crucial. Migrant and refugee women show low use of sexual and reproductive health services, among others because of the assumption that such services for unmarried women are inappropriate. Talking about sex is sometimes, of course, taboo for women from specific cultures, and therefore using sexual health services places women in a compromising situation that requires them to engage in forbidden behavior. So we see these women experiencing a feeling of disloyalty to their culture and religion, along with guilt, self-doubting, shame, as they want to explore and embrace maybe an identity more accepted in the Western tradition. Male circumcision and female genital cutting are areas where strong cultural differences occur and where even Western medical experts disagrees, as well as with cosmetic genital surgery. I don't know if you know, but in 65 countries in the world, we have laws that criminalize homosexuality, mainly for men. 12 of them have jurisdiction in which the death penalty is imposed, or at least is a possibility for homosexual. While same-sex sexual activity could be unremarkable in other countries, but in some context of these countries is stigmatized or perceived as inappropriate. Cultural impact also on which sexual problem people are more inclined to report and the degree of personal distress. For example, men from the Middle East and the Indian subcontinent reported the premature ejaculation, semen anxieties, masturbation worries, and penile size issue as being significant concerns. And in contrast, in the Western population, men are more likely to report a distressing lack of desire or pornography use and erectile problems. Related to women in some conservative cultures, the women's primary sexual concern is vaginismus, and an unconsummated marriage would expose these women to traumatic experience and loss of social status because of their dysfunction. While low sexual desire is more prevalent in Western women, while Asian women tend to report more orgasmic disorder, as lack of sexual desire is considered to be not a problem but a norm. And last but not least, culture bond syndromes like the Dato and Koro syndromes are another manifestation of sociocultural influence on sexual dysfunction. So that said, it becomes clear that a single umbrella classification of sexual dysfunction free of sociocultural context is quite impossible to obtain, as some minorities do not fit inside this classification. Next, please. For all these reasons, it's becoming unlikely that a healthcare professional will not encounter patient or family of patients who hold values and ideas about sickness and health different from their own or the ones into which they have been educated. Aspects of culture such as beliefs about the cause and the meaning of the disease, pain relief, truth-telling, religious belief and practices, the organization of social units, the role of the family in decision-making, moral codes, and so forth, can impact interaction between patient and practitioner. So the clinical realities for the patient and the healthcare provider may be really worlds apart. And often the rules of a culture are not overt or even discussed. So such difference may be hidden by both patient and practitioner, appearing irrelevant until they are broken, and often when it's too late. For example, in most clinical environments, assume the patient will follow the physician advice. However, a patient may be reluctant to disclose all the relevant details of the problem, may not agree with or understand the physician diagnosis, may believe their family will not sanction the treatment, or is inconsistent with their religious beliefs. All these factors would result in low or no compliance. So while the practitioner, consistent with their training, sees and treats specific disease as being similar across people, patients experience illness differently, often with their understanding of the disease at odds with that of the clinician. Next, please. So beginning with a conversation that explores the patients and sometimes their families' understanding of the cause of the disease and the solution undertaken thus far is a crucial starting point, for example, using the claimant's question we saw before. Such information can aid the clinician in obtaining a sense of the patient social construct of the illness, health, and treatment. The patient may not speak the native language or speak it without understanding specific terms or nuances, and this can be embarrassing to them. So translation is useful, but not always the answer. The practitioner should ask the patient through the interpreter, if it's necessary, to repeat the key element of the conversation along with any information and instruction in their own words. So this process can help ensure that the communication has been clear. Also, the development of trust depends on the perception of competence and goodwill, so that the practitioner will act only in the patient's best interest. So patients want and need to be treated with dignity and respect, and trustworthiness that is validated through compassion, altruism, empathy, honesty, all humanity is essential for developing a therapeutic alliance. So I'm introducing a patient-centered care here. Next, please. The nature of the relationship between patient and practitioner weighs most heavily on the practitioner. We need to be aware of that. Adopting a patient-centered approach that is characterized by compassion, understanding, and care that is obvious to the patient and the family generally leads to greater patient satisfaction and better health outcomes. It involves some broad principles that drive communication and interaction, and first of all, the knowledge, respect, and validation of different values, culture, and beliefs. However, this approach never implies that the practitioner retreats from professional standard and principle of ethics. The practitioner concern always need to be addressed, for example, by obtaining complete and accurate information, even when the patient and the family is reluctant to share. However, treating patient as we would want to be treated during crisis or times of vulnerability explain the essence of a patient-centered care. Next, please. So what exactly do we need to know or do to become culturally competent? We need to be aware of our own biases. So working across culture is best learned by reflecting on oneself and patient's life, beliefs, and action. In other words, the idea is that we need to be intentional about the process and not merely assume we can improvise our way. So most modern programs aim to improve knowledge, attitude, and skills, as Veronica said. And as an example, the LEARN program outlines a sequence of steps that can be used to guide the practitioner through a clinical session with the patient. First of all, listen with sympathy and understanding to the patient perception of the problem, explain your perception of the problem, acknowledge and discuss the differences and the similarities, recommend the treatment, but also negotiate the treatment according to the patient culture and resources. Next, please. We need to learn from anthropologists because they encourage providers to ask what patient wants rather than assume. They think holistically, understanding people in context, and they also compare behavior across cultures to reveal the contextual nature of apparent universals in sexuality. So first and foremost, adopting a stance that assumes less than more about patients, their behavior, what is normal, goes a long way towards making room for variation among our patients. Being curious and diagnostic instead of judgmental and prognostic can enable more appropriate assessment and treatment of patients' actual needs. When a patient says they are queer, for example, what might that mean regarding their gender identities and sexual practices? As a healthcare provider, I should ask what I don't know about this term and what I should not assume, particularly regarding health or distress. Also, how I could revise my protocol to signal that I care and I want to know more about their gender and sexual concerns. Next, please. So sexual health can be understood as a set of principles that integrate personal values, ethics, religious beliefs, cultural norms, and unconventional sexual interest or practice. As a guidance, the 6 principles of sexual health that are adapted from the WHO definition provide a map to balance couple and family conversation about sexual activity, functioning, sexual relationship when it becomes a problem or hurts someone. They are grounding rules related to consent, non-exploitation, protection, honesty, shared values, and mutual pleasure. And for those of you who want to deepen their knowledge, you can easily find them online. Next one. My take-home message, though we are trained to understand illness and treatment in objective terms and to view ourselves as neutrally positioned in delivering care, we should also remember that we are as culturally influenced as our patient. So hopefully this webinar will inspire us to go through different steps. Cultural awareness is the first step, and this is the acknowledgement of the difference. Cultural sensitivity is recognizing the needs to respect the cultural difference, and it involves exhibiting behaviors that are considered polite and respectful by the person or of the other culture that is in front of us. Cultural competence is the ability to self-reflect on our cultural values and how these impact the way we provide care. So it includes the ability to assess and respect persons from other cultures and respond properly in planning, implementing, evaluating a plan of care that incorporates health-related beliefs, values, and treatment efficacy. The ultimate goal to me is to achieve cultural humility, in which our practice enables cultural safety. Is a process of self-reflection to understand the personal and systemic biases and develop and maintain respectful relationship based on mutual trust. Cultural humility involves acknowledging we as learners when it comes to understanding another's experience, and also dismantling power imbalance in cross-cultural settings. And finally, cultural safety is about the experience of the patient. It's an outcome, a desirable outcome, based on respectful engagement in an healthcare system free of racism and discrimination, where people feel safe when receiving healthcare. Next, please. As a final note, of course, attending international congresses or webinars is a fruitful way to expose ourselves to understand and respect other perspectives. Still, it's my pleasure to highlight that ESSM, in collaboration with ISSM, runs a sexual medicine school each year where professionals from all over the world learn from each other and share their clinical experience. And it's a unique opportunity to train in diversity, equity, and inclusion. And this year will be in Budapest from 15 to 24 November. And you can also apply for an ISSM grant. So we wait for you. Thank you very much.
Thank you, Francesca. That was excellent. So we have some minutes for questions. And I'm going throughout the first question that we have. So first question, for whichever speaker would like to answer this, what do both specialists have to say about older people's sexuality, still seen as a taboo everywhere?
We give two answers, Veronica.
Yes.
Okay, you are Marisa, you are completely right. I mean, sexuality in older people is seen as a taboo, but there are many efforts that I see in the last 20 years to address this issue, even in in advertisement of lubricants. I don't know if you saw the one of the brand that a few years ago made a full advertisement campaign for lubricants only with older people. So I think we need to be really sensitive to these groups and this population, and not assuming anything, even with the chronic, not only with older people, but all the intersectionality, older people that are transgender, older people that are with chronic diseases, older people that are in intensive, are at the end of their life, older people that are disabled, older people that are Black. So for this population, even more complexity is added, and we need really to be open to listen to their needs and find whatever solution. We have a lot of tools that can aid. We can give many suggestion, even buying pillows for maintaining certain position, for example, for their sexual activity. I think we have a lot to suggest to this population.
Yes, I agree with you, Francesca, in a lot of things that you said. I think that older people in general have received ideas that it's not valid at their age to feel certain things or even to dress in a certain way. So to begin to exchange about how they are feeling, you can start exploring what messages and automatic thoughts that they are having with their feelings and their bodily sensations. Sometimes it's all about giving permission and empowering, because sometimes they do feel that they do have the need, but that their sons or their daughters are in this role of taking care of their parents, and they assume like an authority role, and they feel like they have to have permissions for their families to start new sexual relationships or sexual affect relationship, some new boyfriend or new girlfriend. So they have to ask permission, and they are feeling shame and they are feeling guilt. So sometimes it's useful to explore what these feelings are and what these thoughts are in particular with that person.
Thank you for your answer. You have a great point. So complexity, we need to be open to listening to others' needs, definitely, and explore feelings and false beliefs about sexuality. So does anyone have any questions? If so, please submit your questions in the Q&A.
If I may, I was wondering, after listening to Veronica's presentation, I was wondering the impact of social media, and do you see this often in the young population or in the elderly population? Because I tend to have maybe more young patients that are very influenced by the daily exposure that you mentioned on the social media and their comparison. So what are your thoughts about that?
Yes, what I am seeing mainly these days are younger adolescents. The biggest problem for them when we are discussing about what is happening sometimes is the inability to maintain or to have an erection. Sometimes we discuss the daily routine that they have, and they are using a lot of time in social media, and they seem to be disconnected from reality and feelings. So when it's time for them to engage in a sexual relationship with another, they are very disconnected from their body, the feeling, the capacity to be excited, to become erotic in their bodies. So attention and the ability to connect is affected by these hours and hours of use of internet and social media. So work on gaining focus, working on attention, working on anxiety seems to help a lot in order for them to be able to connect with the person in front of them. That's a thing that I've been seeing a lot recently with 15, 17, 18 years adolescents that consults me. I have not had recently the experience of elderly people with this sort of issues. I don't know if Francesca had.
Yeah, yes, for sure. I mean, older people are not so used to media, to social media, and so on. But I completely agree with you. On the other side, I think that for many young people, adolescents, social media is the social media sometimes is the only place where they can find some communities and some other people that with whom they can share their diversity or their thoughts in a free way, or maybe they can see that they are not alone. So there are both two sides of the coin, I think, on social media, because I see the positive aspect also of it when it become the only standards in which you evaluate yourself. So you don't you don't build a self-evaluation of yourself, a self-validation, not evaluation, validation of yourself, and rely only on the social media validation. That is a problem, I think.
Yes, it's all about balance.
Yes.
Still having time with connecting with real persons as well. So sometimes they get really isolated in these social media apps and just looking for friends in virtual friends only. And that's a big issue, yes.
Okay, so we have two more questions. So first, I will read for you. Okay, looking at the physiology of human beings, is there another function depending on so many aspects as the sexual function, the management of biological processes by society? Question from Maria.
Maria, hi Maria. It's nice that you are here. Your question is is big. Maybe maybe we can think about the death. I mean, is another aspect of physiology of human beings in which there are many aspects to consider. many layers of complexity also. But I don't know if I answered your question. I mean, sex is a sensitive topic, but also death or illness are complex topics with a lot of implication or social cultural implication.
Thank you, Francesca. So one more question. I'm going to read it for you. I like the point of the impact of colonial histories on ethnic practices and complexity of sexuality nowadays, especially in young generations trying to embrace ethnic values and also modernity, which is seen as a colonial background that needs to be decolonized, where the gap is so wide. I wonder what to do, what do you recommend it on such cases for such countries?
Really challenging question. Thank you very much, because first of all, in many countries in which, for example, homosexuality is criminalized, many of these countries are belonging to the Commonwealth. So actually, in those places, in those regions of the world, there was no problem with sexual orientation until from Europe we came and told you that told you a different story. So I'm not a politician. I would love to work to change some thing at the biggest level, but I think that young people are really courageous. And many adolescents, young people really want to find an integration about their several identities. So first of all, I will support, group of young people, ideas of young people. I mean, I would support younger generation in changing the culture. And I would also support much more the continuous education of professionals, continuous education of teacher at school, because young people pass most of their life at school. So there is a place in which we can change the culture. When they are 18, it's too late. I mean, we need to change their mind much earlier. So I would focus my efforts on changing the culture between the several actors that can take decision for the society, but also working on younger generation in the family and in the school. Listening also to their proposal. Sometimes they have really good ideas on how we can change things.
Thank you for your answer, Francesca. Okay, does anyone have any questions? If so, we have still some minutes. Okay, we do have. So how would you address the issue of low sexual desire in a couple where culture determines that men are dominant and women are not encouraged to have sexual goals?
Veronica, if I can answer, but if you want to say your opinion first, go ahead.
Yes. Well, in this case, I would like to know which is the problem that they are presenting. I can have my expectations on what is happening, but I would like to know what is stressing this couple, because maybe for the women having low sexual desire is a normal thing for her, and she's coping with it. is have heard the women from their family having the same problems on and on again, and it's not necessarily giving her stress. So where is the problem here? That the partner wants her to have more sexual desire, is her desire to change things. So I would need more information in order to say, well, what should we do? Because it's a very personalized treatment to desire. It's such an intimate part of a person. What is desire for them? What do they want to feel, you know? So I will explore these issues first.
Exactly. I agree with Veronica. First of all, we need to understand the meaning of the problem for them, who is bringing the low desire, and what for them is the cause, and what is the meaning, and what would be an expected good outcome from therapy, right? What they want to achieve. Because sometimes, expectations are unrealistic. So if they present with unrealistic expectation or unrealistic goal, we should address those. And then I would, I would conduct the conversation through the six health principle. I mean, what to them, what pleasure mean to them, what consent mean to them, how they manage, which are their values, how they manage honesty. Do they want to be honest with each other? So I would follow those. I would follow that map and guiding a conversation about not about who is less or more desire, but what is a satisfactory sexual life for them.
Yes, also because sometimes, as you said, expectations about desire means that, well, desires should come from within, and I should be like in my living room and whatever, and desire will just come to pop up of myself, to appear unexpectedly. And that is an expectation that some people have, like they have nothing, they don't have to work on nothing, that desire will just appear. And this is the only valid expressions of desire. So you probably need to work on that first. How desire is experienced, the variety of forms that desire is experienced, and work on.
So we have the follow-up question. So the woman of the couple wants more desire and pleasure, and the man is not, of course, is not concerned because he's satisfied. So, for example, in this case, psychoeducation could be very, very interesting to them. I would put on the table what you need to develop sexual desire. You need, an internal drive. I would check hormones and biological stuff first. You need motivation. I mean, you build a motivation if the sex is pleasurable, if you have a good memory from the previous encounters. If you don't have good memories, desire will not come just from the sky, right? But also the cultural aspect, the wish. I mean, why the woman wish more desire? To please the partner or to please herself? So I will evaluate different components and what are the ingredients that may, increase sexual desire, make some times for sex, create intimacy, real talks, and not only business talk. Understanding each other, sexual communication, we can do many things in terms of psychoeducation with this couple.
Yes. There is a comment in the chat section that people think wrongly that they do not have to learn anything about sex. For them, sexuality is supposed to be natural, effortless. And that is something that we see a lot on our consultations, right? That, well, I don't know what's happening to me. I should be feeling this in this way. And it's supposed to be natural, and she says that I have to do things in order for her to desire me, but that's not the right way or the normal way, that she should be feeling that because she loves me and nothing else. And that is an important thing that you need to work on psychoeducation. Yes.
But the problem is that sometimes also as clinicians think these things. So
Yes.
don't forget that, because many patients, report that whoever could be a psychologist, a psychotherapist, or a psychiatrist, or a neurologist, a gynecologist, put a label on your desire or your sexual response is not what it's expected to be. So sometimes also we need to be careful on what is our assumption on what is natural or not natural in sexuality. Yeah?
Yes.
Thank you. Okay, so the last question, I think it may possible be our last question is, may I learn your opinion about male and female genital cosmetic surgeries? They are so popular in many countries, in my country, sorry. As a gynecologist and sexologist, I don't deal with those surgeries, but they are changing everything. So many female waiting orgasms from those surgeries.
So, Selchen, I would love to hear your opinion on that, because I think you have much more to say about this than me, for example. I always think that in general, okay, that when you feel uncomfortable with your body, really uncomfortable, and it gives you psychological or physical limitation, you should try to find a solution. And if the solution is surgery, and the surgery is safe enough and is, give you a kind of realistic result, not according to what is popular in that period, I think it's very fine. The problem to me when I assess those patients, for example, is to when someone says that he or she is going for the surgery to please the partner, or the surgery, they expect from the surgery some result or outcome that is not related to the surgery. So not only an aesthetic result, but also, okay, now I will be more confident and meet. I will be more seductive. I will meet more partners. I will do this and that. So surgery is surgery. It change your body, make you feel maybe more with a better body images, but does not miracles in terms of relationship, sexual satisfaction, and maybe your partner will leave you after the surgery. So it's always something that people need to decide for themselves only.
Yes, I think the main question is the why. Why are you planning on doing this, and what do you expect about it, right? Is it just an aesthetic change, or are you expecting, for example, better orgasms, as they were saying? And so you need to give the right information, and people have to understand before consenting this kind of surgeries, that what is the probable outcome that they will get from them. So counseling and giving information and giving the time, space in order for them to process of that, because sometimes it's quite like this anxiety thing that I want it now, because I want to solve this problem now, so give it to me right away. And the importance of having like this time space, no, in order to process all the information that they are receiving and make a more informed decision.
Yep.
Okay, thank you. I wanted to express my gratitude for the opportunity to meet with you today. And our discussion about sexual medicine and cultural sensitivity in diverse communities was incredibly insightful. And I really appreciate the time you took to share your expertise. So thank you again for your time.
Thank you,
Thank you
Angelica.
very much.
Thank you.